Well, hi everybody. My name is Garrett Schmidt, and I'd like to welcome you all to today's live webinar, which is brought to you by bbcexhibithall.com, and it is hosted today by Roji Health Intelligence, and it is titled, "Are You Sabotaging Your ACO Viability?" We have a lot of material to cover today, and I will introduce our speaker momentarily, but a few items of note, just some housekeeping things before we get started. Everybody has joined in listen only mode. This is a traditional webinar format, so you don't need to worry about turning off your camera or your microphone. We can't see you or hear you. But we are going to have a time for some questions towards the end of the presentation. So if you have a question for our speaker at any time during the presentation, you can submit your question using your control module, and we're going to get to as many as we can in the allotted time. If for some reason we don't get to yours, don't worry. Someone will reach out via email to make sure that we answer your question. And we do have a big audience today, so that very well may happen. However, again, we would like to answer your question if we can, so just drop it in anytime. Finally, the session today is being recorded, and what's going to happen is when we're done, maybe an hour or so afterwards, you will receive an email that will have a link to the recording as well as to the slides, and that way you can review it at your own leisure, as well as share it with friends and colleagues, and we hope that you do that. And without further ado, let me go ahead and introduce our speaker today. We have with us Ms. Teresa Hush. She is the CEO and co-founder of Roji Health Intelligence, and she will be our presenter today. So welcome, Terry.
Thank you very much, Garrett. I'm excited to be here in the new year, starting with this really important topic. And what you should take away from this slide is that it's a complex terrain. We're looking down on a lot of cracks in the surface here on viability, and we're looking at a lot of new changes of what's going on in the environment around us. So ACO viability is an issue really of cost and revenue. A little bit about Roji Health Intelligence before I begin into the material itself. We provide value-based care technology and services to provider. We're collecting and curating the data so that you have data-driven solutions in order to target both quality and cost of care. And I'll get into some of the things that we do. But the most important of these relative to what I'm talking about today is Roji episodes, which directly address cost variation and cost drivers. What we're looking at right now, and you see the smoky, potentially fire ahead, is that in healthcare 2025, we are seeing already that the pendulum is swinging to cost control. We haven't been in this situation for a long time, and it will be a very difficult road for us to navigate. So my first question before we get in is, how prepared are you for that change to cost? And you can choose one of these two answers. You can say, you're just exaggerating, we're fine, by which I would say your head might be in the sand, but feel free to choose that answer if that's what you think. Or B, we're buried, but we're really planning our cost strategies right now. Garrett, do you want to run the poll?
Okay. Yeah, we are running the poll now, so it should be up on your screen. And this is just for fun. This is anonymous, and so we're going to show the results here. But this way you can kind of see where you are among your colleagues, because we certainly don't want folks to feel like they are alone in not being prepared. But if you are, that's amazing too. But we're going to leave these results up for just a minute. Or this question up for just a minute, and then in about 10 seconds I'm going to close it down and we'll show the answer. Okay, I think most of the results have come in at this point, so I'm going to go ahead and close it down in 5, 4, 3, 2, and 1. Okay, Terry, I know you're not able to see this on your screen, so I'm just going to go ahead and read you the results. So 11% of the audience today says you're exaggerating, we're fine. 89%, on the other hand, says we may be married, but we're planning our cost strategies.
Well, good. I'm glad to hear that the majority are looking at that because that means you're starting to look at what you might need and what form these cost strategies need to take. So let me move on. And I'm going to go into a little bit of basics on managing healthcare costs. So the traditional way, the way that we used to experience management of healthcare costs came from the payer part of our environment in terms of reimbursement strategies, changes in reimbursement formulas, cuts in eligibility, prior authorization, benefit reductions, um, and I'm including employers in that area as well. Benefit reductions, especially from employer healthcare plans, have really made a big impact over the last several years. Reimbursement negotiations, cutting or cost control as the major negotiating item between providers and payers. Tiered provider networks so that those who had lower costs were rewarded by better access to employees and covered lives. And tiered coverage vehicles like catastrophic health insurance so that people with minor wellness types concerns were simply cut out of the process. So let's take a look at what we are seeing already on the table. So this is a list of proposals that the GOP put out last week. So there are changes in reimbursement and cost formulas, and those include site-neutral payments to hospitals, phasing out Medicare payments for bad debt, which would also, of course, cut the bottom line, modifying uncompensated care payments and removing Medicare funding, adopting block grants for GME, graduate medical education, and changing the distribution of that away from academic centers and towards rural hospitals. A lot of people don't understand how much of the funding for graduate medical education and resident programs has come through this Medicare formula. So it's a huge issue, and Medicaid as well. Removing the 50% floor on Medicaid cost sharing, which is a 50-50 minimum state-federal program. So if that happens, then it would really reduce the funding for Medicaid, and therefore it would cause big cuts at the state level. Per capita caps on Medicaid funding, and eliminating tax-exempt status for nonprofits. There are also big changes proposed in the Medicaid program, changing eligibility requirement, eliminating expansion programs, and cutting Medicaid services, especially home and community-based services. So lots of the traditional proposals on the table right now. And the advantage of the traditional proposals is that they happen fast. You can move into a budget scenario or a bill scenario and get a lot of these passed, and it will happen immediately. This is in an environment where we have health systems that have built up and increased costs over the last several years. There were 72 mergers of hospital and health systems last year. 30% of those involved at least one distressed partner in the merger. So it saved an institution or it saved a community from going without health care. But on the other hand, every single study that has ever looked at consolidations has always found that costs have gone up. So we've got an engine that is not quite in sync with what's coming down the pike in terms of cost cuts. So let's look at this second method of managing healthcare costs. And this was really an effort to put some rationale into the type of cuts and also make providers responsible for their actions that were creating rising costs. So this is value-based care, and we're very familiar with this. We've been working on this now for over 10 years, and there are a number of payment models with per capita or episodic reimbursement. It is moving towards cost caps. So here are a couple that are live right now: ACO Reach, Team, specialty care models are out there, and ACO PC Flex is just beginning. The Medicare Advantage expansion with reimbursement changes is a method of value-based care management of healthcare costs. Why? Because the premium rates per person are capped. On the other hand, what we have seen in the actual data is that the Medicare Advantage population tends to be healthier, and so they cost more than the traditional Medicare program in terms of that premium compared to the actual cost. So we'll see some adjustments there, but that is a tactic that would not be surprising to come out to either under the banner of privatizing the Medicare program or in capping costs in a way that has not worked very well so far through regular value-based payment models. We may see MSSP ACO changes in risks and savings formula. Under the prior administration, under the Biden administration, there were a lot of ameliorating risk factors. Things were slowed down. There were more payment models that focused on giving money to providers to ramp up with technology and so on. But under the previous Trump administration, you saw a much more aggressive stance on direct negotiation with providers and moving people into risk faster. And so that may happen again this time too if value-based care continues under certain payment models. And there may be mandatory participation in payment models too. We will see that a lot of the voluntary nature of some of these models over time may disappear in an attempt to get savings faster. So magical thinking is a belief that nothing is really going to change. We don't really need to work on this. And a lot of us have been in that kind of magical thinking scenario. We can delay movement towards risk. We can slow down the process in payment models. And I think that window is behind us at this point. So the realistic options that I see, and these are my personal opinions, but based on a lot of experience, is that the provider's best avenue for financial sustainability are in value-based care payments, because there are better and more ways to live within the levels that are created there. And with data, there are better opportunities to excel on cost accountability and outcomes in that model. There's a better chance for a long-term strategy for clinical excellence and tying into the workforce initiatives and coming out ahead and intact under a value-based care scenario. And also, it's probably a much better position for competitive positioning with private equity, especially controlling the volume of the physician workforce now, which is about 20-25%. It's really important that all of the parties in the value-based care arena are really looking at a serious attempt at total cost of care control. Another option is reimbursement formula, and other traditional changes will happen, but it can be reduced under better control of total cost of care. So either way, I see that the payment models will have a place in this. It's just a question of how the speed at which the administration thinks that these can happen. and what are the degrees of freedom for people to kind of ease their way into it. Resisting all change is the equivalent to simply accepting the traditional kind of cut scenario. So we've tended to look at these payment models with risk askance, and some rightly so. So let's take a look at the PEG here. I'm going to separate this out into the primary care payment models and the specialty care models. The primary care models that we'll be focusing on today include the ones that are actually live and operating right now. We won't address Medicare, making care primary, but all of these programs are really not open for additional applicants at this point, but they're an indication of what is coming. The other payment models with the emphasis on primary care, besides these particular ones that focus on practices, are of course the shared savings ACOs, ACO REACH, and then 3 of the regional models that are being operated out of the Innovation Center. The key point of all of the payment models is to cap the total cost of care. That's where the tolerance or the intolerance, if you will, exists with the current scenario. The failure to stop the escalation of costs in healthcare, the failure of us to shrink the Medicare budget or the Medicaid budget is at risk right now. So puts us at risk. And it means that we really need to start looking at serious maneuvers to operate through payment models that will actually be effective in capping those costs and move incentives away from volume towards efficient and effective care. It's a divide and conquer change strategy, no question about it, because not everybody will exist in all of the different payment models. So you can have tinkering here and there that will bring groups together under a common mantra, which is to lower costs. And you can address high-cost clinical areas in each of these payment models as well. But they're not innocent, all right? It looks like a duck, it walks like a duck. It's a payment model. It's not a care model, it's a payment model. So let's look at primary care first. This program is actually wrapping up, and I think it's important to bring out the conclusions of primary care first because it was a prospective payment program. It gave practices extra money. It only focused on practices that had experience in care management already. They would have certified systems, sorry for the lack of a space between that. There was longitudinal care management that was funded and behavioral health integration. And we have 2 cohorts. One of them started in 2021, 2022, so they'll be ending in 2025 and 26. And what's in yellow is the most important conclusion. No effect on hospitalizations and Medicare expenditures. So that is what I would consider under the new thinking to be dead on arrival kind of payment plan. When you have PCF payments that are higher than fee-for-service, you expect some return. Now, what the participating practices say is that the money was not enough to support the transformation of those practices and save money, which may very well be true, but who's listening? Making care primary, it's a 3-track approach to fortify advanced primary care management. If you remember in the last PFS rule, there was the effort to discuss how physicians who were simply doing more disease management or management within the practices could code that and also be considered in accountable care relations, which is how CMS will be making the numbers of those who reach accountable care relationships by 2030. But making care primary is interesting because it specifically focuses on building infrastructure and case management, and then optimizing and building partnerships out of that. So it's a good model if you were not in a cost environment, but it does have a component that will be a capitated component. The key features there and the number of participants, a small number of participants really, 8 different regional centers, 10 and a half years. So there is a question in my mind whether it will be allowed to go for that amount of time or whether it will be cut short based on analyses. Includes advanced primary care and gradual movement into value-based payments. ACO Primary Care Flex is another little wrinkle. It's focused on physician-based ACOs, and it recognizes that those bootstrapped ACOs need money in order to be data-driven. And it introduces capitated payments into a core of ACOs that are already in shared savings but haven't gone down the road of risk. And it is intended to be multi-payer. The first participants of those were announced just a few weeks ago and include a lot of private equity funded ACOs, but small physician level ACOs still, and interesting mix, and it will be an interesting experiment. It will be running for 5 years, possibly. Its program is designed to reduce costs and improve outcomes, and there will be a prospective primary care payment. So one of the things that I think this goes into the divide and conquer idea is, as a block, the MSSPs have been more often risk averse, although some are gravitating towards that. By selecting a subgroup within the MSSPs, it's a program to isolate them, put them at risk, have them test it, spread the word, and then potentially increase the risk of other ACOs. Let's look a little bit at some of the vulnerabilities of these models in the environment, and this goes to whether they will be allowed to continue. The timeline for these results is very long, and that doesn't quite jive with an environment that is looking at cost, that has tax cuts on the table and shrunk government. It's flying in that. So it will be interesting to see whether there is the appetite for transformation of healthcare or whether we're just going back to the old days of cuts. In a cost environment, you see a long-term scenario very much in not responding to the kind of incentives in the market. You have to make a quick return on the promises. So the question is, can this dog hunt? And this dog does not look like a dog that can hunt for me, but I think there's a lot of ammunition also and a lot of goodwill and effort that's been built up behind these payment models. I would expect them to be staunchly supported by the healthcare community, and even if as they move to more vehicles that are focused on containment of costs, because it's in their best interest to be able to direct these payment models as opposed to simply absorb cuts. Let's look at some of the specialty models, because I think this is where we're going to see a lot more action. I don't think we'll see as much additional payment models focused on transformation as we will focused on reducing specialty costs, which are about 40 to 60% of the driving costs in healthcare escalation. So we've got 2 big ones right now that are focused on single specialty payment models, and there will be others. the enhancing oncology care model, which is one that we're very familiar with because we've created a specific platform for that oncology care model, and it's full of cost control and cost components. There's also a lot of interest and a lot of things that are focused on the outcomes of those patients too. So you have a good balance in that model, but it is definitely a cost model. Kidney Care Choices, another one that is a really interesting, complicated model, comes in 4 different options, and we'll get into that. Bundled payments for care improvement. This is the old voluntary program for BPCI that will probably be retired over time as the transforming episode accountability model, otherwise called TEAM, announced and live now, will be ramping up. And then, of course, along with MIPS and other models, there are cost measures that CMS is evaluating and adjusting fees based on groups who meet or don't meet those cost measures. So let's look at the enhancing oncology care model because I think it's a good replica of what we'll see. The goal is to transform and improve care in oncology, but it's specifically aimed at chemotherapy. And the idea is to reduce the total cost of care associated with treatment, but at the same time, improve the outcomes of those patients. So there are a lot of different measures of what's going on with the patients. They're being, every practice is being compared with an average across all of the practices that are participating, and they receive a performance-based payment based on their quality. There's 41 practices and 2 cohorts. They started one cohort in July of 23, one in July of 24. So I said it's focused on chemo, and there is a financial risk component. Now, one of the things that's really interesting here is that the episode-based payment model focuses on coordination of patient needs beyond cancer. So there are a lot of things that are going on with patients with cancer, and it's such a huge area. There are 7 cancers that are covered by this payment model, a lot of patients, and a lot of admissions, a lot of ER, a lot of complications with the patients. The practices do get claims data, so it allows them to build clinical episodes beyond the 6-month episodes that CMS evaluates the cost in. In 6 months' time, you can't really see or compare an episode. You can only see a trend of what the costs are from the bucket of 6 months of patients who may have just started chemo or have been doing chemo or are finishing chemo. So the practices are at financial risk because they have an episode-based payment for chemo. Kidney Care Choices has 2 options with 4 different models in that. There is the nephrology practice model, and then there's the multi-provider contracting entity type model. The goals are to promote transplants and reduce dialysis in both of these, but they're slightly different in the way they work because one is aimed only at the nephrology practice itself, and one includes the dialysis center. So it's kind of a difficult thing. Would you be riding on this crocodile's back is the question. And how that will work will be really interesting to see. It's capitation and population-based payments. Has quite a few participants, a 5-year timeline, chronic kidney and end-stage renal disease patient episodes, and depending on one of the 4 categories you're in, you may be non-risk or you're moving into a risk option. The kidney care choices is intended to delay the onset of dialysis for patients in CKD and provide incentives for transplantation. And there's a new model out that is focused on making transplant care more available to people. Team. This is probably the most interesting payment model, I think, to watch right now, because it is not single specialty, it is multi-specialty. It's just starting with a few procedures. And who's on the team? Well, you are, and you don't get to opt out of it because this is a mandatory payment model. It grew out of the Bundled Payments Initiative and now is taking several procedures and making them mandatory and putting an episode-based payment in place. The year one is a practice year. You don't have an actual episode payment model, but the second year you do. So it's a 5-year plan in various regions. The hospitals have to participate. It includes 3 risk tracks, and the first year, as I mentioned, a glide path. There's zero downside risk for the first year and up to 3 years for safety net hospitals, and then lower levels of risk for safety net and rural in track 2, higher levels of risk for everybody in track 3. What's new about it is that it's the first mandatory specialty payment model, and there are several procedures crossing specialties. So we've got orthopedics, we've got neurosurgery, we've got orthopedics again, heart, and general surgery or GI surgery. The key sustainable feature to all of the specialty models is that they do very much focus on cost control. And it's easier to do with those because they're focused on specific procedures, and those procedures can be bundled into mechanisms that allow you to compare costs and identify what's driving costs in particular procedures. It's a real powerhouse, I think. And so the next thing that we need to discuss then, though, is how you would equip your organization for cost control under one of these payment models. 5 tools you really need, and to me, these are like non-negotiable tools. There's a lot more on the table, but what you need is to have the tools to manage the total cost of care, because if you're not focused on the cost of care, you're not going to make it. It's not about reducing your prices and cutting out services. It is reducing the total cost of care that is coming from the clinical services you're providing. If the data is incomplete, or if it pinpoints providers without feedback, the physicians will feel threatened by this, and that will be a problem for you. So the solutions to cost of care must involve clinical and practice changes that enable them to weather the course and understand how they fit into the overall cost spectrum, not in a grade kind of way, but allow them to actually feedback. So here are the specific things you would need to get there. First of all, the aggregated data from EHRs. Why? Well, because cost control is not cost trimming. It's not MEDAX. If you are going to address total cost of care, you need to know what that is, and you need to be able to define it by types of patients and cohorts of patients and patient risk. And that means the data that's in your EHR. The elements of care and variations are going to require clinical analysis, not just administrative analysis of what's driving costs, and it will require the engagement of clinicians to actually fix. Your must-have number 2 is claims data. This is another reason why payment models are important to providers, because they usually come with claims data. And claims data is essential for you to be able to fill out all of the other services and the costs of those services that come with an episode of care that is under an episodic payment model. The specialty claims will be under an episodic payment model, and that will just start rolling out more and more through the next several years. Commercial insurers, however, are hesitant to provide claims data. I know it can be gotten because I got it as a provider and as an employer years ago. But it has to be tied into a negotiation process for being able to do that, and ensuring that, depending on your place in the market, that you're either going in as a CIN or you're going in as an ACO to be able to create a win-win situation to get that claims data. But as far as the CMS payment models, they have come with that, and it's been so helpful to be able to see all of those costs wrapped up. You also need to have a method of revealing the cost variation and cost drivers. It's not a simple, just put it on a map and take a look at all of your, XYZ. You need to be able to determine when your episode begins, when it ends, and so that you always have a comparable clinically integral episode of care for procedures and treatment, let alone chronic disease, but that's more of a primary care issue. For procedures and treatment, there need to be defined timeframes. They need to be inclusive of all the diagnostics that trigger the case, the treatment episode, and so on. That time span allows you to see situations like complications that come out of the treatment, or inpatient admissions that happen during the treatment, or what happens when the patient starts failing, or what kind of comorbidities are you dealing with, and so on. The direct method of responding to those is to isolate those factors in particular episodes and then help you get to the point where you can have a better clinical pathway that takes care of both the best patient selection all the way through the process of identifying how you deal with avoiding complications as well as fixing those efficiently. Those variations need to be compared by clinician, by patient, by regimen in the case of different treatment modules, so that you can see actually which is costing more and where your problems may be responding to. And they have to segue into a review mechanism so that physicians can respond to information that you're giving them about their cost. They need to be able to say, I'm using this anesthetic because this patient had XYZ in there, and otherwise it would be inappropriate. So they need to be able to respond in a way that's easy for them to respond, which gets to the technology you have to share data and get feedback. Physician review and change is the most important thing that you can get to as a mechanism to start controlling the cost, because everything that we've seen shows that they start gravitating towards lower cost when they see that they are an outlier. For primary care, you need to orient yourselves to the highest risk cases to address obstacles that are causing patients to be on autopilot or be at higher risk and have a lot of issues that are standing in their way of getting the best care or even coming into care. Primary specialty collaborations on ACOs in particular will require evaluations between the two, and I don't doubt that ACOs in the future will have the ability to negotiate rates with specialists along these lines, and that this will be an important piece, the episodes in particular, to be part of that mix. And then finally, you have to make everything move up towards the interventions so that you're You're not caught flat-footed once you find out what your problems are. You find an easy way to perform and break the log jam that is causing a patient to not go do well. Every change in cost has an inflection point. It may be that something happened to the patient in the hospital that caused that inflection and the cost to go up. It may be that something happened in surgery, and it could be that the patient came in with it. You need to know what those are and how you can prepare, including whether patients need to have simple procedures or not, depending on their history. And finally, stakeholder involvement. You need the CFO in these discussions. The CFO has to believe and validate the payment, the savings potential for you. They can't be a sidebar or part of the discussion. These, what's going on needs clinical leadership. They can't sit out cost discussions anymore. They have to understand the connection between what they are ordering, their clinicians are ordering, and the referrals and the total cost of care. That information has to flow down the line to rank and file physicians so that they can see what they're doing, including residents. Support for clinicians to manage costs, though, is a critical lack in a lot of organizations. We still expect the physician to do everything, provide cost information to patients. The physician-patient information and discussion of what happens next in a treatment plan needs to be part of a cost discussion too. So that's the detail. Let's just wrap it up. Value-based care is pivoting to cost. We're all vulnerable to MEDAC's cuts at this point. The acceptance of cost responsibility can help to ameliorate those cuts by being more willing to accept risk-based payment models and move away from fee-for-service. But that time is limited. It requires a degree of faith on the part of those who want to speed up the process and just do cuts, and have to convince them. The ACOs especially have to be willing to facilitate changes among disparate practices. A lot of ACOs have kind of hands off on the practices, and now is not the day when you can avoid having the tools to be able to manage costs. So, questions and answers. I'll do the answers.
Okay, yes. So we do have some audience questions today. And first of all, Terry, thank you so much. This was a fantastic presentation. And there's a lot of material here. And obviously, I know some of you will want to watch this later, and we will send out a copy of the recording. But if you have a question right now that you'd like to ask Terry, go ahead and drop it into your control module, and we're going to get to as many as we can. In no particular order here. First question is this: can you provide more details on total cost of care? What is it, and how would your company be able to help us manage cost? Help us manage cost.
Yeah, that's an interesting question because a lot of conversations I've had with providers, they're saying, well, what's total cost of care? And they think that it's their cost. And in order to fix total cost of care, they need to reduce what they're spending. Total cost of care is what other people are spending because of your services. So it's their claims. And in order to reduce it, you need to change the service mix of what's going into those claims, but without making the patient sicker so that it actually costs more. So it's a tricky business, and it is the total sum of Medicare claims is a total cost of care of all their beneficiaries. For employers, it's the total cost of all their beneficiaries. and down the line. So it's what the payer sees, it's what the market sees, and that includes the patient cost of that as well. The way we handle it is to evaluate it on that basis. We look at the clinical data to find out the depth of the services and to see what is being provided with every kind of package of care. And then we look at the claims data to itemize the total cost across all of those services, including those that are not in your network. And those can't be ignored either. That comes into an episode of care module. From there, we go back and look at what's happening to these patients. What are the clinical opportunities for you that we may not have identified before? Where are patients actually going south, like they're ending up in the ER when you don't want them to be in the ER? Is it because they missed a visit, because they didn't have the right care plan? You know, there's a lot of things that go into that question. But identifying them and looking at their risk and looking at their trend lines, predicting who's on the early edge of utilization is one of the strategies that comes out in a condition-based care model and a treatment one, like in cancer. You can see from the history of the patient's complications from chemotherapy, what are the possible strategies to deploy with that patient, get them under a better care management plan, or anti-nausea medication, or a lot of different changes in the actual protocol.
Wonderful. All right, and we've got a lot of questions here, so we're going to get to as many as we can. If for some reason we don't get to yours, don't worry. Someone will reach out via email to make sure we answer it. Next question is, as healthcare costs continue to balloon, do you think that we will shift to old models like HMOs and others that had across-the-board reimbursement?
Yes. Yes, I think we will. I think that'll be on the table. I think it'll be a mixed model that we're going into, and it may look like a scattergram. There are going
Um,
to be some pretty austere cuts, and I think it's especially coming at a time where we've got larger conglomerates now of healthcare that are going to be they've managed to increase the prices, and that is not going to work well. So I do think that there will be vehicles like HMOs. They won't be maybe called that way because that's a bad word, but I think there will be capitated arrangements for employees, and the payment models are a type of capitated arrangement. It's just that they don't look the same to a consumer.
Interesting. All right, next question. A physician I spoke with today told me that 70% of physicians are now employed physicians. Does this make ACO viability, as you presented, have better or worse chances?
I think the number is not actually 70% at this point. It's a little lower than that. But um, how do I think that's going to? I think it makes it easier to adopt payment models because they are employed. About 50% of physicians are employed by hospitals. About 20% are in private equity type arrangements. Both of those, I think, are in good stead to adopt payment models and help to withstand cuts. Part of the risk here, I think, in looking at the MEDAX cuts, a lot of them are directed at hospitals, but hospitals are the engine here. Hospitals are the groups that have pulled together all of the resources. They're funding physicians. So if the hospital gets hurt, what happens to all of the employment arrangements with physicians, especially as we're facing a physician shortage? So it's going to be easier to do payment models, I think, under the networks that we have, but it's not going to be easy to make them by a cost control without a lot of changes in the way everything works. It's designed to still push volume, and it needs to be designed to lower cost while providing the best service.
Okay. All right, next question here is many on the call are likely alert to many of these issues. When do you think these issues will become a crisis relative to trying to survive in fee-for-service model? 2030 or earlier?
Oh, 2030? Oh, yeah, way earlier than that. I mean, the best indicator is to see what happens with the proposals on the table right now. There are going to be a lot of issues if changes in graduate medical education and changes in bad debt and cuts in funding happen. I don't know how hospitals that have a lot of Medicaid are going to cover that care. And it isn't like they're not going to show up. In fact, the emergency rooms are going to take the place of a lot of other venues if former Medicaid patients don't have a place to go. So we'll be back in that world more than we were before. And I think we will see it within the next 3 years, what will really happen. Now, if at the same time we can preserve providers' ability to help direct their own activities and change into more of a payment model type structure, then I think that there's more hope for that kind of crisis to be averted. It isn't like there is no room in the healthcare system for savings. I think we all know that, but finding it has been tough.
Indeed. All right, next question says, Terry, thank you for a succinct overview. Root cause, imbalance of primary care versus specialty care investment in our country. Any thoughts on whether this can be addressed health system by health system?
The problem is the basic supply of primary care physicians. And I don't see how individual health systems are going to address that without, I mean, yeah, you can right size the compensation packages for primary care physicians, which you can make it uncomfortable to be specialists. And I think specialists will be kind of uncomfortable when some of these payment models start coming in. But I don't think that an individual health system has the power to do a right size of primary versus specialties. It comes a lot earlier. And remember, when physicians are making their choices, you're already 5 years into their training. And so we can't make those choices for them any differently at this point. So we've got already a group that will be coming on in the next 10 years that have made choices ages ago, and not enough of them. So a lot of things need to happen. One of the things that health systems can do is help restructure the care so that the physician isn't doing everything and you can deal with the supply better. So primary care is especially vulnerable right now because the physicians still have to do everything. They don't have enough support under them. Who's going to talk about cost of care with patients? Who's going to help them lead through a rural care plan process? Will it really be the physician? Because they don't have time in 15 minutes to do that. Who helps track the patients who are falling out of the care plan? Who does the financial assistance for patients who can't afford, who are diabetic, obese, and can't afford the meds that are not covered by their plans or won't be covered by their plans? So a lot of those issues have to be addressed not with the physician itself, but by the support of the physician so the physician can lead a clinical team and do more.
Got it. All right, we have time for maybe a couple last quick ones. Next one is, are you seeing commercial payers adopt episode-based payment models like Team? Why or why not?
Um, am I seeing that? I'm starting to see some of that. It's coming through, not episodes per se, because it's more of a basket group. They don't have the tools to do the episodes themselves. Episodes are not easy. So what they're doing, and the episodes are also a tool for managing costs better than they are than for payment, quite frankly. So all these episode payment models are paying physicians on an average of what the total cost of the episode is, or physicians and hospitals, because I think there will be models that are very similar to the bundled payments initiative that had a hospital and physician in it, because most of these procedures are performed elsewhere. They're not performed in the physician office, and so it needs to be an arrangement, and that is not well recognized by the payer end. They're seeing all these things without an attribution model to create an episode of care. So I think they're slow to adopt it. As a cost vehicle, they are looking at more of a, here's what you get for, a bundled payment that includes a spinal fusion and a laminectomy, and these basket bundled payments include such a motley range of procedures that they can really help one physician who performs a lot of the lower cost procedures, but not the other one that performs some of the higher cost procedures. So it's a thicket of issues for clinicians on how they actually get the money back. But in terms of a cost control vehicle to evaluate clinically, procedure by procedure, how that is actually controlling the cost or what's driving the cost higher, it's invaluable. So different things. There's going to be have to be an understanding on the payer side of how they can make it a fair payment for the clinician. It won't be fee for service, and the closer it gets to an actual clinical procedure, the better it will be.
Okay. We have time for one more, if it can be like a 30-second answer. And I don't know if that's possible, but what is the best way to address leakage to higher cost providers?
Leakage from the ACO, uh, to have a better primary and specialty collaboration so that your primaries have arrangements with specialists that you've developed a relationship with on cost, meaning there's data sharing about cost. There's no reason why a neutral cost scenario can't exist, and even a method of buffering um, the actual cost data that specialists have. They're loath to share that information with primaries, but
Okay.
having somebody in between can help that.
Wonderful. Well, unfortunately, that is all the time we have. If you have a question that wasn't answered, again, someone's going to reach out and make sure that we answer your question, and which means also go ahead and drop it in now, even as we're wrapping up, if you have one that you'd like to submit. Terry, thank you so much for a fantastic presentation. This was very thorough as always. As we close out, want to encourage you all to head over to BBC Exhibit Hall, where you'll be able to check out the Roji Health Intelligence virtual exhibit booth. And Terry, would you mind advancing to that final
Oh,
slide?
that's right. Sorry.
There we go. And you will see what that looks like there. And in the slides, there it is. There will be a link to where you can actually access that directly, and you can read up on them and what they're doing in the space, and really, educate yourself on Roji and the different things that they're doing, and of course reach out to them directly. And at BBC Exhibit Hall is where there's a lot of wonderful resources in our library, our resource library on a variety of topics, including a lot of webinars, which is where this one will be archived. But we will be emailing out a link to where you can actually download the slides from today's presentation, as well as review the presentation today. And then finally, if you would like to reach out to Roji directly, feel free to do so. Here is Terry's information and Leonard's information. They will both help you out. And if you would rather reach out to me, I'm happy to facilitate an introduction if that would be easier. But thank you all again so much for spending your afternoon with us. Hope you join us on the next one. And until then, have a great rest of your day. Bye-bye.